So, very good afternoon to all of you. I pay my respects to Madam Shalini, who is chairing this panel, and also to all the distinguished panelists and the distinguished colleagues from different states who are present here. So, we'd like to share a few experiences and experiments that we are making in Meghalaya. So, this is in the state of Meghalaya, we have been using an interesting concept, I think. That's why I would like to introduce here a state capability enhancement in a model especially to build the state capability, by solving critical development challenges in Meghalaya. It's not only Meghalaya; it's essentially it's a kind of the states do have a lot of challenges. Coming back to Meghalaya, Meghalaya is one state where we have different challenges, and so what we started actually when we started looking at the challenges initially, when we looked at mostly we started with the technical challenges, saying that there is a deficient health infrastructure, and we started actually this is the way the state has been investing a lot over a period of time. So thinking that by building PHCs and CSCs and the hospitals, we will be able to solve the problem. But like again, we have a problem of trained human resources, and very important thing is that Meghalaya also has a very unique geographical challenges. So like if you ask me, there was one of the important points for safe delivery. Within 30 minutes, we should have a place where actually we can take a pregnant woman when she actually started, experiencing labor pains. But a majority of our state is just impossible to reach out in the 30-minute span to a hospital for a safe delivery. So then we also have these default explanations, like we always say that there is a hesitancy, there is a low levels of health demand. These were the technical challenges. So what we started was that we used an approach. I call it a problem-driven iterative adaptation approach. It's something that we use this approach during this COVID period, and COVID period was a kind of a blessing for the state in a way to understand the deep causes of the health systems and health issues. So when we started doing this, we found more adaptive challenges. So like we found Meghalaya, everyone says that it's a matrilineal society, and whereas we didn't find that women's agency. There was a very low birth spacing, resulting into high maternal mortality. When we did this analysis, we found quite a 87% of the maternal deaths what we have audited, there was no spacing. The spacing that is required, at least 1,000-day spacing, that there was no spacing. So there is there is a teenage pregnancy issues. Even the maternal deaths, again, a large percentage, about almost like a 17% contribute to the teenage pregnant women, who succumb to these are some of the gender issues, and then there's a poverty and low trust on the systems. And then we also found, then based on this, we brought a state health policy. I will explain in the next slide what is that state health policy. And then but again, but the policy is not enough, because again, we require to implement the policy. We require a kind of a lot of focus should be given on the implementation. So that's where we designed this state capability enhancement framework, which I would share. So this is something that we found there's a lack of sense of purpose in our systems, poor coordination among functionaries. So this we brought this state capability approach, to bring clarity of purpose at all levels, including political level, and using this iterative approach for problem solving, and also using the data and feedback loops for learning and collaboration between the different departments and across hierarchies. So this while this is while doing this, actually this is a kind of one thing I would like to share is a 3D healthcare model for achieving universal health coverage. This is it's a kind of a guiding framework. What we are talking about is that, we often actually, in fact, including, in fact, our respected CEO sir is here. I think, when he came to Shillong, we were sharing the same thing. We were more like a sick care, not, very provocative statement, not health care, because when people get sick, then we started actually working on them. So can we actually change that, entire paradigm? So that's where a lot of focus I think we definitely require to give on the preventive care part of it, so especially addressing both the demand and supply side interventions. So here we need a lot of course, health and wellness centers and, early diagnosis using some smart technologies that what we have, artificial intelligence based. And a lot of, we are also trying to redesign this entire primary healthcare, comprehensive primary healthcare, because still when we have had one of the sessions with all the medical officers, looking after the primary healthcare centers and community healthcare centers, we asked about what is that, whom you are covering. Mostly they are covering those people who are coming to the hospital. They are not covering to those who are not coming to the hospital. How actually we can reach out to each and every one. How actually we can do a kind of a Costa Rica kind of a model where, every year, every person, is screened at least thrice if the person is a senior citizen, and if the person is a comorbid condition, so twice, and every citizen is screened for at least once. So how actually we can bring that kind of a comprehensive primary health care. And then, of course, curative is important. Here actually we have this health insurance schemes and, and strengthening the primary and secondary and tertiary care. Here also what we have been doing is that we found we have almost 177 specialists vacant, and out of 30 community health centers, only one community health center is FRU, first referral unit, because we don't have specialists there. So we also have, recently we have signed an MOU with the government of Tamil Nadu to send our doctors and see that like the 6 months EMOC and LSAS and, sonology training can be done. So there's again a curative part, how actually we can strengthen that one. Then enabling part is a very policy and measures, how actually here we found we brought a elected health local bodies in the state. So we have now the village health councils, which are elected bodies, and they are currently, the elections are going on, and this is something that is an interesting thing. And then we putting a lot of gender equality. We brought a women's reservation in the village rural bodies to see that how actually their role and participation would increase in terms of creating that agency. And we also have a social audit law in the state, which actually which in fact does the audit and gives the power to the people to see how these programs are implemented, how they can access their rights and entitlements. So that also we have brought it, it covers about 21 different programs of the state. And we also, interesting thing is like a ECD. We found this is something that is a very, it can be a game changer. We found early childhood development. There's a lot of research is happening. We wanted to, utilize that research, science of early childhood development. So we launched again an ECD mission. So this is and the other is like a CMSMS is a chief minister. I will tell about that one in the next slides. So I just wanted to take this very quickly. As per the WHO definition, as we see, universal healthcare means all individuals and communities receive health services they need without suffering financial hardship. It includes the full spectrum of essential and quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. So here actually we are trying to do a small way to translate these principles into practice. First thing that, as I mentioned, how actually we are trying to cover all the individuals and communities. So there is in fact, one of the things that what we have been doing is this comprehensive primary health care, and idea is that how actually we can make as I mentioned just now, how actually we can reach out to the people, and how actually we can proactively reach out to the people who are not visiting the health facilities, and see that they are screened and they are provided proper health care and guidance. So that's one that requires a lot of sense of purpose and a lot of mission approach, we call it like a mission government workforce we require for that. So we are working on that one. And then we also, as I said, we have just started an experiment using that positive population healthcare management, which is essentially leveraging this digital technology and AI. And of course, full spectrum of services involving these village health councils, to ensure that, there is a full participation, and across the life course, ECD mission, as I've just mentioned, and financial hardship Meghalaya health insurance scheme, which has been brought, in fact, in collaboration, and we are, PMJ, Prime Minister's Jan Arogya Yojana. Here we are providing universal health coverage in the state, in the sense in addition to the SECC beneficiaries, all other families are covered in the state. So this is another thing. And we also have this Chief Minister's Safe Motherhood Scheme, as I mentioned. The real challenge for our state is the geographical challenges, and and a lot of, because we have 85% is indigenous population, so a lot of heuristics behavior, and how to actually really engage with them. So a lot of investment is required. They trust traditional birth attendants more than the health systems, how actually we can really co-opt those systems. So bringing that, we created again a Chief Minister's Safe Motherhood Scheme over and above the National Health Mission has been initiated. So this is a small a slide about each of those things I would like to present it to you. This is a very interesting thing. This is we have been working with, we have a, for initiating, especially leveraging this digital technology, we have a Smart Village Movement project, where we are working with UC Berkeley. And so where we were doing this, essentially how we can create a model where by leveraging this mobile applications, how actually we can promote a better healthcare in terms of like identifying, especially preventing those things at the early stage. So again, it requires a lot of community mobilization. So it's basically data plus community mobilization model. So it's like we have the data, we have digital. So how, if you can actually, bring them together, how actually we can do. So we are doing this exercise, and we have identified about 40 parameters locally relevant, and creating this work. And and this is from sensitization to the health screening, to investigation, to intervention, to prevention strategies. So it's a pilot stage. We're also trying to produce some study, and then we'll share it with everyone. Then the Village Health Council, as I mentioned, I think this is something very, in fact, our CEO, R.S. Sharma sir, actually, he was there in Shillong, in fact, telling about this important thing, because health cannot be delegated. Health is something that everyone has to take responsibility. Everything can be delegated, something can be delegated, but not the health care. So how that, to bring that sense of participation, we've brought this thing, and it's giving us some very interesting, initial, quick wins for us, because the participation of the people, and how actually they are trying to save the lives of the mothers who are high-risk pregnant mothers in the interior places. A very interesting thing, work is going on, but it's essential. It also provides a lot of, it solves the demand side problem of the healthcare. We could see that one. So though we have these committees are there, but elected bodies have always a greater role. And here we also brought the women self-help groups very actively in this village health councils. The village organization president is the co-chairperson of this village health council. So then the ECD mission, as I mentioned, I think you all aware, like if you invest 1 rupee or $1 in early childhood development, you would get 16 times the benefit, cost benefit analysis. This has been proven. There is a Nobel Economics Prize was won on this particular research, and we have to really, this is something that we wanted to really do, because we have actually in our country, we have all the programs are there, but only thing is that really prioritizing and bringing that focus, and so that's what we are doing now. And in fact, we are working with ADB and and also on this particular idea. So where the idea is that if you this is a demographic dividend to really create. If you invest, the data shows that if you really provide that caregiving support, and especially not only that just nutrition, but also like especially the enabling environment, the socio-emotional support at the children and we are just trying to transform this Anganwadi centers as early childhood development centers. So this actually will give us, we are hoping that we can actually achieve a cognitive capital in future. The children who pass through this particular schools, like the way Tamil Nadu children who pass through the midday meal school, how actually they did differently at later point of a time. I think this is something that one thing we are really looking at it is again this we are also trying to create some kind of a test kind of a thing to share with the rest of the the states. So then I mentioned about Meghalaya Health Insurance, and this is essentially we put an OPD package, because our to provide the antenatal care, because at least people can go to the private hospitals wherever we have the proper facilities are there for antenatal care. So we also put this OPD package, and then this I mentioned about Chief Minister's Safe Motherhood Scheme. We have now we have a data that shows that entire, as I mentioned earlier, we have a mother app where actually we have the data of all the pregnant mothers. We also know their status, who are actually high-risk pregnant mothers, whose expected date of delivery is in the next 14 days. And then, we actually try to bring them much before the so that we can save the mothers. And so a lot of the focus is there. Here also we brought how to actually integrate traditional birth attendants so that into the health system. So we're trying to find local solutions for the local problems. This is one of those state capability framework that what we have been saying is that we definitely require, and also providing that sensitive support that is required to build the trust. So the data is interesting data that we could see with the results of the entire approach of the systems approach. We can see there is the maternal deaths. Actually, we could see some a kind of a reduction, and also we could see that there is a sense of purpose among the entire workforce, whether it's a medical officer, as a block development officer, whether it's a DM or DC. This is the most priority for us in the state. So this is these are some trends. But like this, I just wanted to end up with we are using this kind of a framework, as I mentioned, especially promoting this local leadership through problem solving. That's like an iterative approach. We have this weekly check-ins, and we do this, and then building that citizen state responsive systems, like creating those community institutions, social audit mechanisms, that kind of a thing, and effective use of research and data, what I just mentioned, and also the creating that sense of agency, not only just accountability. Especially the government workforce is a huge latent potential is there. So we are trying to how to convert that latent potential available within the government workforce, who are generally not very accountable, but how to convert that into a kind of a mission-driven workforce. So that's the one area that where we are working, and then of course identifying this, addressing systemic challenges like gender barriers and and the poverty and other socio-economic determinants of health, and finally political supportability. It's very important. Our state is number 4 in terms of the healthcare expenditure. So our chief minister and our ministers and very they're very passionate about this, and they're also measuring their success through this indicator. So generating that political supportability in all these interventions is also very important for for bringing that sustainable change, especially when we talk about providing universal health coverage, and providing universal health coverage means creating life. Creating life. I would say currently our life expectancy is around 70 years, and Costa Rica life expectancy is about 81 years. So even if we create a 10 years, it's about 1.3 billion people we have. So 13 billion life years can be created. With this small quote from Ellen Johnson, so the former Liberian president, I would like to end my presentation. Thank you.